Hi, everyone, both here, but many more of you who are online. Welcome to another edition of our conversation series sponsored by the Yale Institute for Global Health. I'm delighted to welcome everyone to this event, this hybrid event. In addition to the Yale Institute for Global Health, or YGH, today's event was sponsored by the Walker Fund of the Macmillan Center. The first cases of COVID-19 appeared in Pakistan in February 2020. And as one of the most densely populated countries in the world, actually several areas are very densely populated in Pakistan, the country was fairly vulnerable to adverse impacts of this new pandemic. And like any new pandemic, like many countries in Asia, particularly South Asia. During today's event, which is, as you know, those of you who have been following these events, follows a series of conversations over the last 3 years on various global health related topics. But one strand that has run through a lot of these conversations, certainly not all of these conversations, is the pandemic response. Starting with Dr. Anthony Fauci in 2020, going through Dr. Tedros from WHO, the UNICEF directors, 4 directors of CDC, and so on and so forth, and leaders from around the world. So in this context, we will discuss the challenges of a pandemic response in Pakistan, which is very interesting in the sense that it has a federally devolved health system, but there are several functions that are centralized as well. And there is a specific need in a pandemic to make real-time data-driven decisions. We will outline how these challenges were overcome, including lessons for around the world on how to respond to future pandemics. Unfortunately, this is not the last infectious disease-related event that we'll be seeing. And one misnomer is that it's a 100-year pandemic, but 100-year looking back, looking ahead, is likely to be, there is evidence that it is likely to be more frequent. With that in mind, I'm very, very pleased to introduce our honored guests, Dr. Faisal Sultan, who's the former Special Assistant to the Prime Minister of Pakistan on National Health Services, Regulation and Coordination, or in short, he had the portfolio of the Federal Minister of Health in Pakistan. Dr. Sultan is an infectious disease physician, and has been the CEO of the largest cancer hospital. In fact, the largest cancer hospital network in a large country like Pakistan for several years, and in addition to more recently serving in his government capacity. He's a graduate of the King Edward Medical College in Lahore, but did his residency here in Connecticut at UConn, and had, if I can say so, a formative rotation at Yale, where he was inspired to do infectious diseases. And some of his mentors are still at Yale, and credits our inspiration, this institution's inspiration, to change the trajectory of his career. He also trained in infectious diseases at Washington University School of Medicine. He serves on several high-level national and international fora, including Pakistan Science Foundation, Pakistan Medical Research Council, and the HPV, Human Papillomavirus Advisory Committee for the World Health Organization. He also served on the board of a Global Alliance for Vaccine and Immunization, or Gavi, the Vaccine Alliance. Welcome, Dr. Sultan.
Thank you.
So first, we'll start with a broad question. How did Pakistan do in responding to COVID-19? And how was Pakistan's response somewhat similar to? And what were some of the differentiating features compared to other low and middle income countries in sub-Saharan Africa, in South Asia, and Southeast Asia more broadly, and in the Middle East?
Right. So I think, some of it is subjective, obviously. I think generally we were able to do well, but there were a number of measures or metrics that one could think about or talk about that would make one think that we came out of it somewhat okay or better than some other countries. I think very broadly one could look at things like mortality, things like overload of the healthcare system, or how far and how fast the economy recovered post-COVID or during it. And so I think a number of these measures point out towards a somewhat, I wouldn't say easier time, but a better outcome than some other countries that went through. Comparisons are odious, and it's very difficult to make across, especially across countries with different systems and political structures. But for similar sized countries with similar challenges, I think I would say that many other large federal structure countries did suffer quite a lot, and relative to them, I think we came out a little bit ahead.
So in terms of, yes, so you're right that in terms of data collected by our Walden Data and others, there were mortality sort of metrics that were lower, et cetera, and sort of independent data validation has shown that if you can triangulate those data, et cetera. Obviously, there are data issues in any pandemic, but broadly speaking, sort of there have been some of those features there. In terms of, take us behind the scenes, because one of the lessons this pandemic has taught us that it's not necessarily the technology, it's the operations, how the public health response is managed. Take us behind the scenes. What were the leadership lessons as a public health leader you learned in responding to the pandemic?
I think some of the most important lessons, or if I could call them leadership lessons, or lessons in general as well, that came out of this, and they certainly relate to some of the behind the scenes efforts that were made, relate to the fact that coherence and data-driven decision making, and that too in such a way that is well communicated, well received, and then the ability to follow through on many of those recommendations and mandates or guidelines or restrictions that we all came about with. So the ability to do this in a coherent, data-driven, consistent, and flexible way was the key lesson that came out of this. When we started out, I think within Pakistan, as in across the globe, there was confusion as to how to deal with it. People had seen what had happened, say, for example, in China, in Wuhan, where they had the ability to shut down, an area or a city or a province, and yet continue to function as a country. Then we all saw images and news and numbers coming out of some of the first European countries, and then Iran next to us, that suffered heavily through mortality and how the disease spread and how it pressured the healthcare system. So there was indeed confusion and a whole range, a diversity of opinion on how you could deal with it. On one hand, there were people who were the naysayers, who felt that this was all a problem that didn't exist, the nihilists. And then on the other hand, there were people who wanted very early and very harsh and very blunt measures, which would be very destructive for the country as a whole. And so you had to find not just a middle path or an equal, equidistant middle part, but a response that one would tackle the pandemic, but would also allow life to go on. So this sweet spot did not necessarily have to be right at smack in the center, but it had to be data-driven and driven by the science of it. And it was finding this by creating data flow networks, creation of expertise pools, the ability to analyze some of this, the ability to scale up, whether it was oxygen or PPEs or beds or the raw supply of oxygen, to predict where the next outbreaks would be, and then to, of course, ensure that vaccination happened. So all of this was a complex dance that had to be done. And I think the most important lesson out of this is that we may be a federal, and many other countries may be federally devolved, diverse countries, but for a pandemic response, we must have the ability for a cohesive central response.
So a little bit more operational details.
Yeah.
So I think this is a really good sort of overview. In terms of, tell us a little bit about your emergency operations center, which was called the NCOC, the National Something Coordination. How did you get the data in a country? How did you use geographic systems? And a little bit about specific supply chain issues like oxygens, et cetera, that how you estimated that need, and how did you respond to that in real time?
Right.
Because as I recall, Pakistan had strains on this oxygen supply chain, but it never had real shortages and that kind of a cycle when there are shortages and then people sort of keep it for their families and their hospitals, et cetera, and that kind of stuff. So how were you able to avoid that?
Right. So let's begin at one end. So the first of all was the governance end of it. And the NCOC got formed really as part.
Well, what does that stand for?
The National Corona Operations Center.
Yeah.
And so, the Command and Operations Center for Corona came into being when the National Security Council figured that it really was a threat to national security, and for the government to be able to have a whole of the government approach, which connected all the federating entities, had expertise marshaled in, had a civilian head of the response, but have a military arm to help them with a lot of the follow-up procedures that were required, and to be able to connect to not just the provinces but elements and entities within the federal government. So that was the governance piece that got fixed with the formation of the NCOC. The cadence was it met every day for hours at a time, and it was all data centric. Talking about data, so one of the most important bits to be done was to create a real-time flow of data. For example, testing. For example, fill up of beds, the number of oxygen beds, the PPEs required. So all this required that we had efficient data flows and databases that talked in real time. So we connected all the nearly 200 labs, 173 I think was the max, that were, for example, testing for PCR for coronavirus, and to connect them either directly or through the provincial dashboards. And so we were able to piggyback onto what existed as the IDIMS, which was the polio dashboard, added a few fields to it in real time, and so the data flow started to become real time and accurate. Then, of course, the other important thing was we needed to know where space was, or where you had actually spare capacity, because we realized that the epidemic would not be even. You will have surges in one place and relative spare capacity, perhaps in the same town without being aware of it. So this visibility of the resource required a resource management system. So over 3,000 healthcare institutions were connected to it in real time, gaining a number onto how many people were, how many beds were available, how many oxygen beds, how many vent beds, and so on. And similarly, an infrastructure for the information system for vaccines had to be created. All of this got helped tremendously, and I have to tell you this, because all Pakistani citizens have a national digital identity. All of us have a number, and so all tests that were done were tagged to a national number. All the vaccines that were given were tagged to a number, and so this the ability to capture this data was important. The other layers that were added that really helped us was a geographic layer. So if we knew where somebody was, and based on census data, we could tell where there were hotspots in complete real time. And therefore, that helped us to have nuanced and targeted those so-called smart lockdowns instead of shutting down the entire city. So in a sort of quick breathless way, I've told you how we were able to utilize some of the data and technologies that existed. We used geolocation. We also used how people's geographic address matched up. And not only was that used for contact tracing and for hotspot detection, but also how we scheduled people for vaccination. So we would schedule you close to your house or your address to a center that was near you. And of course, we went down by age. So all this was helped by having that information at a central place.
So elaborate a little bit more on the so-called smart lockdown, especially in early phases of it. How was that different from the blanket lockdowns, et cetera, and what enabled you to do those kinds of preventive measures? Obviously, later in the pandemic, you didn't do that, especially after the vaccine became available. But in the relatively early phases, how did you switch to that strategy?
Right. So the first lockdown wasn't terribly smart on a number of occasions. It wasn't smart in the sense that it was not targeted. Entire provinces got shut down, or large cities within provinces got shut down. This happened on the 23rd or the 24th of March 2020, and happened more as a cascade of shutdowns. And I was reminded almost, that famous line as the First World War break out, and looking out the Prime Minister's window. I think it was the Treasury Secretary who said in the UK that, the lights out are going out all over Europe, and they might not see it lit over their lifetime. And that was almost the feeling some of us got, that almost a cascade of shutdowns were happening, and we really did not know how and when we would be able to walk out of those. But that was more a reactive phenomenon. Once that happened, we got to work and said, look, in a country of 220 million people spread over thousands of miles, we cannot be having this blunt approach. And we were able to figure out the presence of the disease because it was tagged. All those 200 labs, or nearly 200 labs that were contributing, were mandated to actually capture the computerized national identity number. And therefore, we knew by geography as to approximately what areas were hotspots. But not only that, we also had geolocation information, because in addition to the number, we were also capturing the cell phone number. So we could tell approximately in an anonymized fashion where the hotspots were. And then for contact tracing, obviously, the contact tracing teams in all the 4 provinces and the 6 or 7 federating units had the ability to do contact tracing based on that geolocated information. So once we got through 1 or 2 cycles of this, we realized that we could use heat maps for the entire country. And those heat maps were then communicated out to the provincial entities, who then could act on it in a very sort of smart way. So the lockdowns became very tight, few neighborhoods, few streets even, and without shutting down the entire city and paralyzing life. So I think, and this continued almost till the end. Each time there was a surge, we were able to say, okay, fine, this is where the surge is, and within the city, this is where the worst part of the surge is. And whether it had direct mobility impacts, or it actually altered behavior through messaging, is unclear. Obviously hard to ascribe in a dynamic way, but I think all of these things had an effect.
Good. So look, you are a physician executive, physician scientist, but in a pandemic, by necessity, a whole of government response is needed, and the whole of government is headed by politicians. So any lessons, in this private sanctum, well, no, we're being recorded, but any lessons about dealing with politicians? And in Pakistan, to set the context, had provincial governments from different parties. There was a prime minister, is a prime minister. It's a different person in charge now. And so how did you deal with that? And what are some of the dynamics that are illustrative of that interaction?
So just to test out the whole thing and to test everyone's nerves and ability to work with everyone else, there was a full rainbow of colors as far as the parties were concerned. So almost each province had a different government from a different party. And so that was one of the initial difficulties. People singing slightly different tunes, and by design, so this is the other bit. By design, a federal government is more worried about the overall economic impact, whereas provincial or local or state governments are more worried on the impact at a more local level. So by design, almost by default, their angle of view is slightly different. They have different perspectives. So to merge and bring everybody to the same place required the usual things: conversations, reach out, professional to professional, peer-to-peer conversation. So some of us in the NCOC were able to reach out to our professional colleagues that were advising the Sindh government or the KPK government, and well, there at least it was the same PTI government, and to other colleagues across the country. So one was this conversation, this reach out, this cobbling together of opinion and views. That was one. The other bit, of course, was that the NCOC was headed by Mr. Asad Umar. Asad was a fantastic colleague to work with. He was the planning minister, had worked in the private sector for a major food company, and had been in politics for 10 years. And so he understood both sides of the divide. And I think he was able to have the centrality and the coherence of this discussion. He had private relationships and knowledge of all the politicians and the political entities that existed in the federation, in the federal entity, as well as in the provinces. So was difficult. I personally had an easier time in that sense that I had tremendous trust with the Prime Minister, having worked for his hospital for 25 years. So that was a peculiar advantage that's not so easily reproducible for everyone. But I think that was a personal advantage that I had, the trust of the chief executive. But I think overall, regardless of that, you have to cobble together these conversations, these unions, and a trust network that eventually got built and was very robust.
So just switching to your other role, which I would say your day job, which is a physician and a physician leader at a major sort of network of cancer hospital, which is the Shaukat Khanum Memorial Cancer Hospital and the research center. Describe your experience running and almost setting up a major tertiary care entity. Rightfully, there's been a lot of focus of global health on primary care, et cetera, and obviously no country or region can have a claim to a robust health system without a robust primary care system. But obviously, things like cancer happen, and they require major investment in tertiary care hospitals. So set the stage for our colleagues here. What was the situation of cancer care before the entity was established? What are some of your lessons from helping establish that and expanding that hospital and now a network of hospitals?
So mercifully, for these 2 years that I was in the government, I was on sabbatical from here. So I wasn't wearing both hats, or else I would have gone completely off the deep end. But so I started working at Shaukat Khanum as soon as I moved back from the US. This would be 1995. And my initial role was that as an infectious diseases physician. And I waded myself into, or I think life and luck and happenstance took me to the chief executive's position. Of note, I actually had no formal managerial or administrative experience or background or formal education background. So it was a bit of a chance that the board took on me, and a bit of a chance I myself took on myself. So I think through this time, if I could summarize this, I think the most important thing that I have seen through Shaukat Khanum is the fact that the board had very complete clarity of mission. That hasn't wavered. There hasn't been mission creep. They haven't confused themselves into what they are all about. It is about cancer, and it is about having a tertiary care organization. And it is about making sure that there is access to the poor, that the fundamental pivot on which the hospital was made was the fact that you needed to provide access to those that cannot afford it. And so all through the hospital has remained true to that mission. Things that I've learned along the way, a lot of it I ended up using, and I think they came in extremely handy during my time in government, were things about collaboration, about humility, about understanding that your responses and your plans change, about being data driven, about having very important information and technology backbones. At Shaukat Khanum, we've had an electronic health record, a fully automated electronic health record since 2005, and a homegrown one at that. So all of these things require the ability to work with people and work with all sorts of people. And I think those were some of the key leadership lessons that I was able to learn and continue to learn even today, where the mission and focus of the hospital remains that person, that child or that adult who is otherwise not able to access quality cancer care, and to provide them with a top-class place where there is absolute even handling of their care. It does not matter. We really do not care if you are paying or you're not paying. As far as the institution is concerned, everybody is handled the same way. Some of those lessons also came in very handy when we actually rolled out the vaccine in Pakistan and making sure that it was completely fair across the board.
So interesting. So we will go into the phase where we will take questions from our online and in-person attendees. We'll start this time. We often start with in-person audiences. We will start with online folks. We already have a few questions, but others are welcome who are sort of here in person to come up with your questions, etc. So there were two related questions. One was, obviously it's a large country. You were dealing with provincial governments, etc. But there are large cities like Karachi, like Lahore, and all sorts of municipalities. Even smaller ones are pretty large compared to,
Sure.
because it's a large and densely populated country. So how did you interact with them? Or that was a sort of a 2 degrees removed interaction. Did you directly interact with them? And the second thing was the other end of the spectrum, and it's interesting that both of these questions came together, was how did you reach out? So while there are highly densely populated areas, there's a long tail of sparsely populated, hard to reach locations, and there are major equity concerns in this kind of a pandemic. So how did you address these two ends of the spectrum?
Great question. So first of all, as far as the structure of government is concerned, as far as the official position is concerned, we could only act through the provincial governments. So the NCC and the NCOC had provincial representation.
And what does NCOC?
So the NCC was the governance entity. That was the the National Corona Committee, which actually was chaired by the Prime Minister, and had the chief ministers as part of it, and the membership from the NCOC sat on it as well. So that was the upper governance committee, and the operational bit was the NCOC, which met on a daily basis. And so it was structured that way. So we had to, and we legally have to go through the chief ministers or their representatives. But our reach out there was focused on individual or larger cities or cities with larger problems or current problems at that time. So, for example, in many of the waves, the timing of the two waves or the waves were different. So, for example, in some waves, it was Karachi that was first and Lahore later and the other way around. So our ability to reach out to these individual cities were through the district administrations, but we always worked through the chief secretaries of the provinces. So in our structure, the chief secretary is the senior most bureaucrat that reports to the chief minister of the province. And so we always reached out to them. But to be perfectly honest, we would also, by keeping them in the loop, in the copy list, we could reach out through the NCOC to individual district commissioners or to the commissioners of the cities directly as well, where there was,
So the commissioner is the city level,
is the city or area or zone level, division level highest bureaucrat and so on. We also had to, of course, by default, engage all the relevant line ministries. So if you were going to talk about, say, convincing the mosques to obtain to create some distance between how people pray during Ramzan, for example, you had to engage to the Ministry of Religious Affairs. So the whole of the government, that was the beauty of the place. The convening power and reach of the NCOC was massive. So you could get anybody in the room, real or virtual, and reach out. And that included the private sector. When it came to making sure that we had enough oxygen, we were able, within the first wave of the pandemic, we were able to raise our oxygen production, the raw oxygen production, 66%, by just unlocking a few roadblocks that existed on some plants that were either dysfunctional or did not have one supply or the other, and to sort those out. So it was vertically, down to the provinces or the cities and districts, but also horizontally within the federal government.
So it's an interesting question, but before that, is there any question from the in-person audience? Yes, go ahead. We'll take one from here.
Yeah, sure. So my question is, you talked about the difference between being reactive versus proactive, just looking ahead in time. So I know that there was a big problem in the procurement and distribution of the vaccine, especially during the onset. Was there an effort in Pakistan to create its own vaccine? And was it, if yes, was it successful? Because I believe until this point, there's no local vaccine there.
Right. So the engagement with the potential vaccine suppliers started in the summer of 2020. And we actually created a vaccine experts advisory group that took a survey, a landscape view of the entire likely chances of what was going to reach the pipeline. And despite this, as was expected, as almost all of us could predict, that when actually the vaccines came on board, there would be a clear supply issue. And those countries that actually had inherent or native supplies would end up supplying themselves first. This nationalism or vaccine nationalism was almost predicted. So yes, we had initial difficulties in jump-starting the supply. We got some donations from China, and some old strategic partnerships worked out there, and that was donation. But the hiccup came when Gavi, that had been hoping and leveraging on supply from India, for example, for the AstraZeneca vaccine, that supply got disrupted because India had its own wave, and predictably and understandably they had to serve their own population. And so our initial supply, which we thought would come from Gavi, the whole thing had to be turned around. We thought that initially we'd be able to deploy through Gavi and buy later. And whereas it got turned the other way around, we had to buy initially, and then Gavi followed up later. In terms of domestic supply, the one success we did have was fill and formulation of a single-dose Chinese vaccine, CanSino. But beyond that, we do not have, at this time, a national supply of an indigenously made vaccine, whether developed locally or whether manufacture of an externally developed vaccine. This is a key gap that needs to be filled.
Yeah, so let's take.
Thank you so much for coming to speak with us. So my question was on this note of indigenously sourced vaccines. We saw with polio virus in Pakistan prior that there was an issue about the source of the vaccine and how it came from the West. So I'm interested to hear your perspectives on how information was disseminated regarding the vaccine and sort of how vaccine hesitancy was perhaps addressed through the NCCC.
Right, so this is an oft-asked question, and I'll tell you that while one can never swear that there was no vaccine hesitancy, that'd be a silly position to take. But if I could venture to say that, relatively speaking, we had very little vaccine hesitancy or hard vaccine hesitancy as far as the COVID vaccine was concerned. In fact, I would argue that when we did surveys, as well as when the practical rollout happened, there wasn't any hesitancy. There may have been laziness and in certain circumstances where the vaccine was available and people required to be reminded or reminded of not only the availability but near availability, and then flipping the thing around and taking the vaccine to them instead of asking them to come to the vaccine center. So of the thousands and thousands of vaccine centers that were created, eventually we realized, no, we need to go to them. So the mobile vaccination teams were created to make sure that there was ease of access. As far as the part in the brain is concerned, which is to convince them, the mental part of it, I don't think we had too much of a difficult time in making that happen. By and large, there was acceptance of the fact that a vaccine was required. We did use many levers available to us. For example, we are a young country. 25% of the a fourth of the country goes to schools, colleges, universities, etc. So we said, look, all faculty and staff at all educational institutions need to be fully vaccinated. And so that was sort of an obligation that was put on them. Of course, they could opt out for medical reasons, etc. But by and large, and the uptake was in the high 90s. Similarly, for a number of other things, transportation. So for airlines, pretty soon there was a time when you could not fly without a vaccine certificate. Restaurants and the hospitality industry was really encouraged very strongly, if I could use that word, to make sure that all their patrons were indeed vaccinated. So all these levers were used, but we never had hard resistance to vaccine acceptance. And it wasn't national, how shall I put it, the vaccine acceptance or preference, if I will, was not based on national vaccine or source of the vaccine at all. The public formed its own views on what they wanted, and we could see this on vaccine centers. So we were one country that were offering 7 vaccines at one point, and more or less it was up to you. You could really go get what you wanted. And to keep the entire system flowing, and imagine a country, 220 million people, and the entire vaccine network flush and flowing with all the vaccines available, especially when some doses were, so the Sputnik, for example, had dose 1 and dose 2 that were different. So you had to make sure that if you had X number of potential vaccinees that had gotten dose 1 of Sputnik, that the second dose, which was obviously different, used a different virus vector, was also available. And despite that, I don't think that was the major challenge. Our challenge initially was the initial supply, as was asked. But once the whole thing got flowing, that wasn't an issue.
So yeah, there's another one, and then
Thank
we'll
you.
go online. Yeah.
So in thinking about the national digital ID number you mentioned, it's very exciting because I know we have a lot of struggles around that in the U.S. What were some of the challenges faced in kind of reaching those those in marginalized community who might not be counted in that, and what are some of the costs and benefits of the ID numbers in that context?
So the digital ID, as you perhaps know, predates all of this. The first attempts of this were from the 70s, mid-70s. So almost all of us have had a number, and then that eventually got transformed into the computerized number two decades ago. So we've all had, one way or the other, a national digital identity. The estimates from the organization that manages this data is that about 4 to 5% of people don't have it. They are either those that are below the radar, haven't bothered to get it, or whatever sets of reasons. They're marginalized or disadvantaged in some way, or have never felt the need, perhaps. One was to encourage that those that are Pakistani citizens and can easily get that, to say, well, look, here's an opportunity. We even worked with NADRA, that's the entity that runs this, to create mobile teams to go and actually register people. Here's an opportunity, here's the vaccine, please get yourself registered, and so on. So creating that ease. But then there are populations that are actually not Pakistani at all. So the largest of those were Afghans. And they have very often an Afghan card. And so that was added as to the list of eligibilities where you could actually go and show that and get that done. Beyond that, there were other situations where they were truly undocumented people. And so the vaccine database, the NIMS as we call it, had provisions created in it to enable vaccine centers to create a record and actually give them the vaccine. We did not do this initially, primarily because for a massive deployment of 200-something million people, to ensure that it was documented, there was no pilferage, theft, or substitution, etc., that we remained somewhat true, and there was fidelity to the CNIC, the national ID. But as we went along, we realized that we're not going to get out of it without making sure that it was truly equitable and reached all the marginalized parts of society. So yes, it had mechanisms built in to allow people without a digital identity. And we were happy with working on the edges of a little bit of, I wouldn't say irregularity, but lack of accuracy. You can't be 100% accurate in such a large deployment. So we built that acceptance mechanism in it.
So I have a question from Dr. Sten Verman, who is online. So Dr. Verman just recently stepped down as the dean of the School of Public Health, and he has a long history of working in Pakistan and training who are now leaders in Pakistan, in the academia and in the government as well, through especially the Sindh government, but also at the federal level, folks who went through several of his training programs over the years. So he sort of has a question around that there in recent years, the Pashtun population in the Khyber Pakhtunkhwa province and what was formerly the federally administered tribal areas, now sort of they are called settled areas, etc. And even sort of in Karachi, it's in the south as well, the population has a recent history of hesitancy and refusal around polio vaccine. So while there may not be much of a hesitancy at the national level, but did you have a communication strategy to preempt or respond to communities that have refused other vaccines?
So I met Dr. Verman just 2 days ago at ID Week, and we had a brief conversation. So I know him very well by reputation. I've met him before as well. The short answer is that we did not find the kind of hesitation or refusal that we find with polio with this vaccine at all. And it was not regional in that way as well. So in other words, the reach out of these vaccination teams was easier. And for some reason, and I can conjecture as to perhaps what those reasons are, it had an easier sell, or it has an easier acceptance. We also tried to have a mutually beneficial relationship between the two vaccines. So during the polio campaigns, perforce, because the same vaccination force is out there, we had to pause or slow down some of the COVID vaccine. But then we were very conscious of the fact that other waves were coming. It was very important to get as much of the population covered while there was acceptance and before fatigue or indifference built in. So we would create a situation where people would go get the polio vaccine, but also they would have nearby mobile vaccination teams for the COVID vaccine, so that if there was acceptance, we could do it. So in other words, we tried to help both of the campaigns by synergy with each other. Fortunately, we were fortunate that the heads of the EPI, the Expanded Program for Immunization, as well as the head for the polio program had great working chemistry. Both became good friends with me, and one actually I had known from earlier. So that personal chemistry and trust also helped in synchronizing these campaigns. I have to tell you that for the measles vaccine, though, we actually had to hard stop the COVID vaccine because the rate of adverse reaction for COVID, for measles vaccines are higher. And therefore, the experts that looked at it said, well, look, you're likely to damage the credibility of your COVID vaccination program because of the expected or the estimated adverse effects that are going to come from the measles vaccine. We did 90 million kids during that time. So that was also a huge campaign. So for those 12 days, we had to pause the COVID vaccination. So we really did not have that kind of regional or ethnic based resistance to this vaccine as we have seen with polio.
So another question is, so by the way, I'm looking at my phone, not because I'm sort of texting my friends, is because that's where the questions are coming from, online questions. So they haven't sort of had developed the technology to directly transmit it to my brain chip. So there's another follow-up question on since you mentioned polio. What is the situation? So Pakistan had made progress around eliminating and near eradicating polio, but we know that new cases are there. What is the latest situation? I know that you have stepped away from your government position, but obviously you know the situation.
Yeah,
there.
so I have to answer this one carefully. I have less restraint in a non-governmental position today, but this one I have to answer carefully because of the intense polarization of political perceptions, etc., within our country. Anyway, so for a full straight year and more, we had 0 polio cases. And not only that polio was at low numbers, but our environmental sampling also, and we talked about environmental sampling. Environmental sampling also suggested that we were actually making good headway. We were worried, however, from good data that we knew that there were reservoirs, and those were particular areas. And those had to do with some of the same populations that Dr. Verman was talking about, especially mobile populations as well as from certain ethnic groups that have a certain amount of mistrust and distrust. I think what has fundamentally happened in those places is that the quality of campaigns, and one can't say it any more delicately than this, that the quality of campaigns leaves something to be desired. Now, there is a slider that you have to move. To reach into hard to reach populations, it is crucially important to have people from within those communities, or else your campaign is not going to succeed. But when they are from within those communities, your ingress into the stringency, the fidelity of those campaigns is not as high as it would be had it been normal employees that you hire in. And so therefore the chances of fake marking or of being worried that, okay, if they report non-vaccine acceptance and the next day because this is the way it is, the next day the deputy commissioner is standing outside the house and saying, well, why are you not getting vaccinated? So to prevent such social...
Sorry to interrupt. So the deputy commissioner is also a senior level
bureaucrat who's there. So because it is such an important topic, the government has raised the heat on this matter. And so therefore, the intense governmental focus on that zone or household or neighborhood would mean that that neighborhood might feel that they have been squealed upon by that last vaccinator who they refused to. And so the social ostracization or worse that could happen sometimes creates these situations where people will either mark fakely or will just report that they've vaccinated. So it is the quality of campaigns which is sometimes poor in these hard to vaccinate areas where the trouble arises. It has solutions, but requires diligence and continued pressure. I'm pretty sure it'll happen.
Yeah. Do you have a question? No. Okay. So there was a question at the back that I saw. So yeah, this one and then, yeah.
Thank you so much for coming. I wanted to ask a question more from a policy perspective. In the tri-state area and many regions globally, the fallout from COVID resulted in a backlog and essentially a complete moratorium on a lot of routine screenings, such as breast cancer screenings. It's Breast Cancer Awareness Month around the world. And during COVID, a lot of people were not able to tackle their disease at the earliest, especially in the United States, and it had a lot of health equity implications. I'm very curious to know how this was managed in Pakistan and what was the impact in cancer hospitals where people needed routine screenings or biopsies and surgeries, not just for the late stage cancers, but for early stage diagnoses. Because in the United States, an approach that was taken resulted in early stage just being tabled entirely, which for people who are diagnosed early is their best opportunity to tackle a disease. So I'm very curious to know about the COVID fallout. Thank you.
So if I may add sort of another question to a supplemental question to that. So you're seeing, the tertiary care facility, are you seeing any data trends that people are now presenting at a more advanced stage of cancer, et cetera, related to that?
Okay, so there are two parts of this question. One, the more policy part, and the other is the more sort of the impact of that policy, if it were. I'll tell you that one of the most important arguments that I could use personally at the time against broad, blunt, and blunt is what I should say, lockdowns, was exactly this. That on one hand, we do want to save lives. Forget the economic argument for a second. You want to save lives, but the disruption to preventive systems, to health promotive systems, early detection, and just routine care. A woman that may require to have a C-section and she ends up delaying it because there isn't adequate care available. Even mundane stuff like this was this was the argument as far as people like myself made, and the Prime Minister as well, the ex-Prime Minister, Mr. Imran Khan, that we cannot do it at an either or. We have got to try to find a path that allows us to slow down things where it's required, absolutely, but to continue the rest of life, whether healthcare or other things, unabated. So overall, it did have an impact. So when you have in the initial shutdown, the so-called lockdown, the first one, there were, and we had data that some catch-up immunizations, etc., had to be done or given. There were also some reductions in the pickup of tuberculosis cases, for example, in our context, that you expected to see, and they were not there. And then they did eventually come through. So the policy was to ensure that we could continue things as much as possible. And I just gave you the other example about measles. Here we were, the NCOC said, well, look, guys, Dr. Faisal Sultan, you may be the health minister and you have other fish to fry, but we are the NCOC, we are worried about COVID. And I would say, well, look, you are wearing one hat, I've got the other one, and I cannot let measles go through or polio go through. So all those campaigns had to be juggled. So all these balls had to be juggled at the same time. So as far as policy was concerned, the governmental policy was concerned, it was to try as much as possible to not halt services. However, as you correctly mentioned, because many hospitals reduce services, and what ends up gets thrown out is stuff that can wait, and usually that is earlier or milder disease of one sort or the other. So it did have impact. For our own hospital, Saad, I have to tell you, because I was away, I wasn't part of that decision in my place, but we did not shut down services. We continued services, and so we did not have backlogs of that kind. Various mitigation strategies were used, including remote clinics that the whole world employed. But at least for Shaukat Khanam, there was not a major...
So you're not seeing any more severe sort of cases at presentation?
We are not.
Okay. So there was a question at the back, and then we'll come to online questions, and then we'll come back to in-person questions.
Hi. So my question is kind of similar category that previous questions have been. What was the impact of pandemic on childhood routine immunization in Pakistan? And how is Pakistan dealing? First, are there any numbers to reflect on what is the magnitude of that setback, and what are the strategies that Pakistan is using right now to mitigate that setback?
So yes, as far as through the first shutdown, which was from the 23rd of or 24th of March 2020, for about 3 weeks, there was a drop in for that time period. But it was transient and it was all caught up. In fact, if anything, the routine immunization coverage across the country has gone up. The delta for over a 3 or 4 year time frame, this is by third parties, not by the government, is 10%. So actually, a lot of people are pleasantly surprised that despite COVID, the routine immunization numbers have actually gone up. I think some of the synergies, and this is interesting, some of the can-do win approach or a winner approach that has happened because of COVID has really energized some of our vaccine programs. I do think that after COVID, where good 90% of the eligible population as of mid-September had at least 2 doses of vaccine. So for a country like Pakistan, where people expected that this is going to take years, it has actually leapfrogged many more developed countries. So I think that it will synergize and help the RI program, the routine immunization program. But obviously, I'm not in government right now, so I can't give you the official figures. But I do think that the dent was there, but it was temporary.
So yeah, so Gavi and UNICEF, and actually UNICEF and WHO estimated, and Pakistan was one of the countries that did not see a major backslide at a year by year basis. Obviously, there was that backsliding
those 4 weeks,
in that period, etc. But the concern a lot of us have is that there are second, third order effects of major disruptions. Do you think that kind of because there's fatigue in health workers, there's the system, even if it delivered during the immediate phase, do you think the circumstances are such that at least the coverage will not drop? Because despite the increase, because of its size, Pakistan is one of the top 10 countries with 0-dose children.
Yeah.
So there has been improvement, but it's a large country. Like the other countries like Nigeria, etc., are also large. So do you think things will remain at least stable, if not improving, in these this year, 2022, where the data hasn't come out, and 2023?
So I'm going to go out on a limb here, and perhaps this is reflective of my nature and optimism. But I think that it will not be a dip. In fact, you may actually see an improvement, because the whole vaccine program got so much kudos, so much recognition in the country, that I think that their ability to understand that they are able to provide vaccines and deploy vaccines well is going to be higher. I mentioned very good numbers for the measles vaccine. Again, third-party evaluations, etc., will come in and we'll figure out. I think it will not go down and perhaps will improve. But again, this is just my view.
So there are a couple of questions here. This one, and then.
Thanks so much for being with us today, and really insightful to be able to look back and consider the pandemic and what happened in Pakistan. And I have to say, always wonderful to hear encouraging, and you've given us a kind of encouraging picture of public health in Pakistan. I think probably at the back of all of our minds is, of course, the flood and that impact. So can you shift gears and give us a little bit of a, look into the crystal ball a little bit and tell us what you imagine or expect the public health picture will be? I'm specifically thinking of dengue. Yeah. Now my entire family all over Punjab has dengue fever. Is that kind of thing? Could that be endemic or pandemic? Or what do you imagine we kind of started the conversation with the idea that there will be more and more pandemics. So what do you expect? Anticipate?
So the hat I now wear is fully of an infectious diseases physician, working in a cancer hospital. So with that caveat, I'll give you my view, because I cannot give you an official view. I do not have access to those numbers. But let me tell you something interesting. The same room, the actual same physical room, and some of the same infrastructure and people that were used for the NCOC are being currently used for the flood coordination. I am told that it is proving to be a harder job because perhaps of the nature of the problem. But nevertheless, the same kind of effort is being put in. Longer term, what will happen, I do not know. But I think that at the present time, yes, for vector-borne diseases, dengue in particular, we keep worrying about malaria, but what we've seen more, perhaps for whatever set of reasons, is dengue. Well, that's one. The other thing that I do worry about is the kind of question that was asked earlier. So in the really flooded areas, because road networks get disrupted, the nearest health facility that you're used to going to may not be that easily accessible, and something, the other on the other side of the road is closer or more practicable right now. And people are not used to switching care this way, especially when you're poor and have less mobility. Those are the things that I do worry about. I think that this is a space that needs to be watched and reviewed, not just for vaccine preventable diseases or vector-borne diseases, but also for things which we consider routine. In other words, antenatal care, nutrition, just routine care for illnesses that, if not taken care of in time, go bad. So that's kind of a very non-professional, I apologize, kind of view, but I'm being very careful with what I say because I do not have an official role.
Yeah. So I guess this is the last question from the audience because we have to sort of wrap up.
Thanks for joining us, Dr. Sultan. We've spoken a little bit about marginalized communities and difficult to access areas. I wonder if you could speak a little bit to any specific challenges you may have faced in trying to access remote northern border regions like in Gilgit-Baltistan and Jammu Kashmir.
So just to set the context for, the question was about remote to access areas. The parts of Pakistan, especially the ones that you highlighted, are mountainous areas where, especially during the winter months, sometimes the access is blocked. There are nomadic communities that go out to meadows for years, for months at a time, etc. And so that was the question. How did you, some specific issues from that
Right.
part?
So specifically, let's address Gilgit-Baltistan, for example, as an example. I think that we were surprised, and I have to tell you this was very much dependent on the quality of the local leadership, especially the bureaucratic leadership that existed. Places that had good good chief secretaries and dynamic chief ministers clearly made a difference. And you could see that it's almost in real time deployment of vaccines, provision of facilities, making sure that the data was correct and real time and no gaps were happening. So GB in particular, I can tell you, was exceptional. We felt that they were able to, and we focused on them for vaccine, for example, because GB is a popular
Which is Gilgit-Baltistan, same area.
Sorry, I keep
Yeah.
different country. So Gilgit-Baltistan is a popular tourist destination, and so it was very important to ensure that they indeed were protected. So their uptake was not any worse than the rest of the country, and in many situations they were way ahead of everyone else. Partly because the actual numbers, the population is small, but yes, the area is large. Some of access issues are there. We even had to, as an example, switching gears from vaccine, for example, we realized that we could supply the rest of the country relatively quickly if there were shortages in oxygen, for example, so you have manufacturers in south, manufacturers in the north, and to move trucks this and that way. But the northern areas are snowbound in the winter, and so it's hard to reach them. So the strategic reserves and large reservoirs of oxygen were created in Gilgit-Baltistan just specifically to make sure that they don't get blocked out during those efforts. So we did not see any clear numerical differences that would concern us. One little marginalized population, women. So when we started out, there was a huge delta. There was a fair amount of gap between the uptake between men and women as far as vaccines were concerned. And as time went on, this is one metric we tracked, and as time went on, it actually narrowed. And we felt that the most important way to do this narrowing was to take the vaccines to them instead of expecting that they're going to make the visit. Men are more mobile, they may be riding a motorcycle, etc., going somewhere, reaching, and so it was important to address these. So this was another number that we felt was one to target, one to narrowed down. I do not know the last number, but I know that it was a 60-40 split in January. So still there was a gap.
So before we wrap up, a brief sort of question and hopefully a quick answer. And you have been very comprehensive and crisp in your answers so far as well. So in that same spirit, what are some of the things you would do differently, or the country should have done differently? Lessons learned, but specifically, what some things are, we learn lessons from them. There are other things where they serve as the control group, et cetera. So what are the things that you would do differently?
I think one is we should have handled the initial lockdown a little bit more differently. I think I keep criticizing it. I think that's one thing. I think the nuance could have been put in a little bit sooner, but perhaps it was a bridge too far. It was difficult to do. That's one. The other one that I think we could have done differently was improved our communication of the why. Very often what we were saying, we were doing this, okay, we are shutting down schools, and then everybody said why. And so the why probably had to be enunciated better. These were the two things, I think, one in the realm of data-driven decision-making, fine-tuning, and better comms.
Yeah. So thank you very much, and I'll sort of apologize to the audience. I know that there are questions. I know that sort of I switched off the vibrate function of my phone because I learned it the hard way earlier, because a lot of the recordings have that little buzz, etc. But I know I'm getting a lot of texts with questions. People are not texting me directly, by the way. We have someone actually sort of transcribing questions from Zoom to me. And we, as usual, we are not able to answer all the questions or able to put all the questions in front of our guest. But thank you, and thank you for the specific and candid conversation around the pandemic response. And for the rest of you, we'll continue this series, the conversation series, with a lot of exciting guests that will be coming to Yale. Thanks a lot.
Thank you very much.
Bye.